Okay, so today we're going to be going over hypertension medications. We're going to be diving a little bit deeper into the pharm aspect of the meds, going over the mechanism of action, the indications, contraindications, adverse drug reactions, and things like that. Of course, I'm going to keep it high yield. I won't waste your time with things I don't think are important for you to know for the boards, but most of the stuff is pretty important, and you do need to be familiar with these. So let's go ahead and get started. For hypertension medications, there's really 6 classes that you need to be familiar with. That's going to be your ACEs, your ARBs, calcium channel blockers, beta blockers, alpha-1 blockers, and diuretics. So let's first get started with your ACE inhibitors. That's your angiotensin converting enzyme inhibitor. And all medications in this class are going to end in pril. So PRIL, that's going to be captopril, enalapril, ramipril, benazepril, and lisinopril. So those are the medications in this class. Again, they're all ending in pril, so you can recognize them when you see them on a question. As far as the mechanism of action, it's basically like what the name states. It's inhibiting the conversion of angiotensin I to angiotensin II by inhibiting the ACE enzyme. So if we take a look what that looks like, we can see here we have angiotensin I and angiotensin II. So what ACE inhibitors do is inhibit the action of ACE. So they stop this action here, so angiotensin II can never be made. And we'll go over what ACE is also responsible for, which is also bradykinin breakdown, which will be important later when we go over the ADRs. Now, why is it important that angiotensin II isn't being created? Well, that's because angiotensin II is the primary action is vasoconstriction. So we're blocking the production of angiotensin II, so we're not having vasoconstriction, which means we're going to have the opposite, vasodilation, and we'll have both a decrease in preload and afterload because of that. So the main thing that you need to know is ACE inhibitors are stopping angiotensin II from ever being made, therefore stopping the action it has on vasodilation. Now, as far as indications, this is a first-line monotherapy medication for hypertension. So it is one of the 4 classes in a non-complicated hypertensive patient. You can use it for congestive heart failure as well. It's a first-line med for that. Coronary artery disease, patients with a previous MI as well as an acute MI. And then the one you really need to know, this is going to be diabetes. Diabetes and nephropathy. So this is used in all diabetic patients, whether they're hypertensive or not. Once they reach around the age of 40, every diabetic patient should be on an ACE or an ARB because it prevents the progression of diabetic nephropathy. So that's really important, that one you definitely need to know. Now let's move on to the adverse drug reactions, and I have a pretty good way for you to remember them. We'll go over that in a minute. But there's a few things that you need to know. So hyperkalemia is a big one. That's one of the more important ones that you need to be familiar with ACE inhibitors. Cough related to bradykinin. And if we take a look at the actual diagram and see, so what I went over before, what's important, so we inhibited ACE's action, which is good because that stopped the conversion of angiotensin I to angiotensin II. So that's a positive thing. But what also happened is when we inhibited ACE, ACE has another job, and the other job that ACE has is actually to break down bradykinin. And what bradykinin does is actually it has inflammatory properties. It increases nitric oxide, fibrinolysis, as well as some other things. And if we don't break down bradykinin, if ACE is no longer there, it can lead to a cough, and it can also lead to angioedema. So those are some things related. Those are some of your adverse drug reactions because we're inhibiting ACE and we're inhibiting the action of ACE. So all related to the bradykinin, cough, and angioedema are important for you to know. Hyperuricemia is another one, so you want to be careful in this drug with people with a history of gout. And then first dose hypotension. So when a patient takes this medication for the first time, normally within the first 90 minutes, or if you're making a dose increase, there is a potential for hypotension and even syncope with the first dose. So that's another one that's important. Now, black box warning, you do not want to use this medication in pregnant women. Absolutely contraindicated in pregnant women, fetal toxicity, so avoid this. And all of your pregnant patients cannot use ACE inhibitors. Now, what do you need to know for ACE inhibitors and how do you remember it? You need to know a guy named Chad. So Chad takes ACE inhibitors. Chad likes taking ACE inhibitors because they control hypertension and diabetes, first-line hypertensive med for diabetics. Chad does not like taking ACE inhibitors because they cause cough, hyperkalemia, hyperuricemia, angioedema, and dose 1 hypotension. So hopefully that helps you. I feel like this is a pretty good mnemonic that I came up with. I have to say that I'm kind of proud of this. So remember Chad, and then Chad's going to tell you what you use this medication for, hypertension, diabetes, and then Chad's going to tell you all of the adverse drug reactions. So these are the 5 that you need to know. So cough, hyperkalemia, hyperuricemia, angioedema, and dose 1 hypotension or first dose hypotension. So as long as you can remember a guy named Chad, you can remember all of the letters in his name to tell you what you need to know about the medication. So that's a nice easy way for you to remember it. Okay, so let's move on to the cousin of ACE inhibitors, and that's going to be ARBs. So angiotensin II receptor blockers. So all medications in this class end in sartan. So losartan, irbesartan, candesartan, and valsartan. So one easy way to remember that, maybe not easy, but it always worked for me, is sartan kind of sounds like Satan, and then angio, like the first few letters, are like the first few letters of angel. So I always thought of angel and Satan. I don't know, maybe that works for you, maybe it doesn't, but that always helped me to remember. Anytime I saw sartan, I thought of Satan, and then I thought of angel, and that helped me with the first few letters there. So maybe it'll help you, I don't know. As far as the mechanism of action, it's very similar to ACE inhibitors, but the difference is instead of blocking ACE, instead of inhibiting ACE, so the angiotensin II is never made, instead angiotensin II is permitted to be made in this case, but what happens is we block the receptors. So even though angiotensin II is present, it can't act because it can't ever attach to the receptors and take action, that vasoconstriction. So that's the only difference. It's the same outcome, but it's different because now we're just blocking the receptors rather than stopping the creation of angiotensin II, which is important because we're not inhibiting ACE. And if you remember what I went over before, ACE is responsible for breaking down bradykinin. So if we're not inhibiting ACE, we're no longer stopping the breakdown of bradykinin, and meaning you're not going to have cough or angioedema. So if we take a look at a diagram here, this was your ACE inhibitors. Remember ACE inhibitors, we inhibited ACE, meaning that ACE no longer has its effect on bradykinin. But your ARBs down here are different. They're allowing angiotensin II to be made. They're not affecting your ACE. So you see your ACE inhibitor up here. So that's not happening here. ACE is still being made. So ACE can still break down your bradykinin over here, and it can inactivate this peptide. So you're no longer going to have all of the things we went over before. So that's the important difference, and that's really the only thing you need to know about ARBs is this medication is going to be used in patients who developed a cough or even potentially angioedema from ACE inhibitors. Now, there was a lot of studies and things like that, and they were saying that, well, maybe you could still get the angioedema with ARBs, but it's pretty well agreed upon now that that's not the case. And if you had angioedema with an ACE, you can give an ARB and it'll be safe. Now, as far as the indications, it's pretty similar to ACE inhibitors. First line med for hypertension, as well as your diabetic patients and any patients with chronic kidney disease. So pretty similar as far as the indications. Now, as far as your adverse drug reactions, you're still going to have hyperkalemia, but you're not going to have a cough, you're not going to have angioedema. That's really the key. So hyperkalemia is still present, but that cough and angioedema no longer present. That's really the main thing you need to know with angiotensin II receptor blockers. Now, hyperuricemia is kind of controversial. Sometimes you'll hear that it has an effect and it can increase the uric acid. Sometimes you'll hear the opposite. The one thing that's certain, that's agreed upon across all literature, is that losartan is kind of this outlier, and losartan has been found to definitively lower uric acid. So complete opposite of what we saw in ACE inhibitors. Losartan actually has the opposite effect, and it can lower uric acid. So as far as hyperuricemia, don't worry about it too much, because anytime there's any question mark on something, they're not going to ask you it. But know that losartan has been found to lower uric acid. That one is for sure. Now, a black box warning is the same as ACE inhibitors. You're going to have your fetal toxicity, so contraindicated in pregnant women. So not a lot to know there because it's so similar to ACE inhibitors, so I don't want to go too far into this medication, but those are the main things that you need to know. Main thing is no cough. That's the main thing there, no angioedema. Okay, so moving on to our thiazide diuretics. Now, the thiazides that you need to know, main one that you'll always see is hydrochlorothiazide, but there's also chlorothalidone, there's indapamide, metolazone, I always have trouble saying that. Chlorothalidone of all of these actually has the longest duration of action, so sometimes they may ask you a question related to that. That's one of the keys about chlorothalidone, but HCTZ, the hydrochlorothiazide, is the one you'll see being used most often. Now, as far as the mechanism of action, it's pretty simple. It's really just preventing sodium and water resorption at the distal convoluted tubule. So if we take a look at a diagram here, you have the co-transporter here, the sodium chloride transporter. We just basically shut this down. Sodium chloride cannot get into the blood and reabsorbed into the system, so they just go out through the urine, And if you remember, anytime we have sodium going out, what follows sodium? Water. So water is going to follow right along, and we're going to have a flushing of all of the sodium out of the body, as well as chloride and water. And what happens with that is we basically just have a mild volume depletion. So if you remember, anytime a patient becomes volume depleted, they have hypotension because you have less circulating blood in the body. So that's essentially what's happening here. You're flushing out some of the water and the salt, so you have a lower volume of blood in the body and a lower volume of fluid in the body, which leads to this mild volume depletion, which leads to a decrease in the blood pressure. So very simply, you're just preventing sodium water reabsorption at the distal convoluted tubule. So don't make it more complicated than it is. Now, as far as indications, this is a first-line monotherapy for hypertension in your non-complicated hypertensive patients. And then another thing that you can use it for as well is peripheral edema. So if you have this excess fluid in the body, you can use thiazide diuretics, and they work pretty well. Not as good as your loops, which we'll go over after, but that is another option for peripheral edema. Moving on to the adverse drug reactions, this is mostly going to be related to all of the electrolyte abnormalities that we're going to have, because we have this ionic imbalance from all the sodium being flushed out. So a lot of the things that you're going to see are a lot of electrolyte problems, as well as some hyperlipidemia, some other things we'll go over. Now, the only two things that are going to decrease with thiazide diuretics as far as your adverse drug reactions, this one's obvious because I said we block the sodium receptor, so it's not getting back into the blood. So hyponatremia, so low salt in the blood, and then hypokalemia, so you're also going to have low potassium. Those are the only two things that are going to decrease. So if you can remember that, I have a way for you to remember the four things that go up. So there's a lot more things that go up. This one's easy, and just also remember potassium is affected as well, and it'll decrease, so hypokalemia. Now, what's going to increase? You're going to have four things that you're going to see increase with thiazide diuretics. So hyperuricemia, gout-related, increased uric acid. Hyperglycemia, mild increase in your blood sugars, possible with thiazide diuretics. Hyperlipidemia, as well. This is another mild increase in your lipid panel. And then hypercalcemia, so potentially an increase in calcium level. So these are the four things that you're going to see increase in thiazide diuretics. Now, how do you remember the ADRs for thiazide? So I want you to remember the sentence, thiazides cause glucose to be oh so elevated. So you remember hyperglycemia was one of them. So remember, thiazides cause glucose to be oh so elevated. And this is what I have for you. So thiazides cause glucose to be oh so elevated. So what does glucose stand for? It stands for glucose, hyperlipidemia, lipids, hyperlipidemia, uric acid, hyperuricemia, calcium, hypercalcemia, and then oh so elevated. So remember, thiazides cause glucose to be oh so elevated, and then you can remember your four things that are going to be increased here, and then you just remember oh so elevated. So you remember these go up. So glucose, lipids, uric acid, calcium are oh so elevated. So just remember glucose for thiazide diuretics. You can remember everything that goes up, and then hopefully you can remember that salt and potassium are going down. And that's really all you need to know for the thiazides. Now, moving on to the potassium-sparing diuretics. Medications that you'll find in this class are going to be spironolactone, triamterene, amiloride, and eplerenone. The one you'll hear talked about the most is normally going to be spironolactone because it has so many different uses we'll go over in a few minutes. Now, these diuretics, as the name states, are basically increasing diuresis without the loss of potassium. As we saw in the thiazides, we were losing potassium. We had hypokalemia. So if you have a patient who that already maybe is hypokalemic, or they're at a higher potential to be, you can use potassium-sparing diuretics instead. Now, as far as the mechanism of action, it depends on the drugs we're talking about. There's two basically subclasses as far as the mechanism of action. Now, triamterene and amiloride are going to block the epithelial sodium channel and the cortical collecting duct. So if we take a look here, they're going to block this channel here. So sodium and chloride are not going to be going into the distal convoluted tubule here, and they're not into the cortical collecting duct here, are not going to be going back into the body and recollected into the blood. So this actually affects potassium as well. So the sodium potassium pump over here is affected, and instead of potassium being pumped back into here into the urine and being flushed out, this is actually shut down as well. So potassium is going to stay in the blood, so you have potassium retained, and then your sodium and your chloride are going to be flushed out. So that's the way that works, just a basic understanding of how that's going to be working. And again, that's taking place in the cortical collecting duct. That diagram was a little misleading because it had the distal convoluted tubule, but that's what we're talking about there. Now, spironolactone and eplerenone act differently. They're actually not doing the same mechanism as we saw with those medications. They work on aldosterone, and they're aldosterone antagonists, and they decrease the effect of aldosterone. And if you remember, the principal effect of aldosterone is to balance sodium and potassium in the body. The more aldosterone is released into the body, the more sodium the body retains, and the more potassium the body loses. So as you can imagine, a drug like spironolactone or eplerenone that are aldosterone antagonists, which decrease the effect of aldosterone, would have the opposite effect. So we're going to increase the sodium excreted, and so we'll have less sodium in the body, and then we're going to decrease the potassium that's excreted. We're going to retain more potassium in the body. So that's how these two medications work. They're aldosterone antagonists. And then the fact that they're aldosterone antagonists have some other effects in the body, which we'll go over when we go over adverse drug reactions, as well as the indications for these medications. Now, as far as the indications, again, it depends on the ones we're using. Hypertension, but it's not a first line. They're actually pretty weak, and these drugs are a lot of times combined with either a loop or a thiazide because they don't work very well by themselves, but you can combine them to kind of offset that potassium loss. So normally it's not a first line medication, and if you do use them, you'll normally combine them. They can also be used in congestive heart failure. Really, that's going to be your spironolactone and your eplerenone, and they actually have proven mortality benefit, which are one of only a few classes, including your ACEs and some of the beta blockers as well. But there's only a few medication classes that improve the mortality benefit, and spironolactone and eplerenone are both those medications that can. Now, spironolactone and eplerenone, because of their anti-androgenic effects, can actually be used in a number of different things, like PCOS, cirrhosis-related ascites, even acne. These medications are pretty versatile in the things that they can be used in. So those are some other options as well, not just the hypertension and the CHF. As far as your adverse drug reactions, hyperkalemia, obviously, or retaining more potassium, so you do have a potential for hyperkalemia. And then the spironolactone and the eplerenone, because of their anti-androgenic effects, can cause gynecomastia, decreased libido, erectile dysfunction as well. And one thing that I want to mention that you should remember is a lot of times you'll see spironolactone mentioned with gynecomastia. That's just one of those questions that they like to ask. So remember, spironolactone, gynecomastia, that's a big one. Okay, so let's move on to our loop diuretics. So loop diuretics are going to include furosemide, that's also known as Lasix. I'm sure you've heard that name used before, torsemide, and bumetanide. Now, these are going to be your most potent of all the diuretic classes. They work the best out of all of them. And the way they work is they inhibit the sodium-potassium chloride cotransporter of the thick ascending limb of the loop of Henle. So what they do here, they shut off this cotransporter. So you're going to have sodium, potassium, chloride all coming out, which also affects your calcium and your magnesium. So all 5 things can be affected in loop diuretics. So this is what's going on here as far as the mechanism of action. Now, the indications, you can use this for hypertension. It's not first line, but really the main thing you're going to see loop diuretics used in is edema, pulmonary edema, peripheral edema, patients with CHF that have all of this excess fluid. Like I said, these are the most potent of the diuretic classes. They pull the fluid off of the body really well, and they work really well for decreasing excess fluid in the body. So that's one of the main uses you'll see for these loop diuretics. That's really important, especially for symptom relief in patients with CHF. When they have all that buildup of the fluid in the lungs, these meds work really well at that, especially the Lasix, the furosemide. So that's the main place you'll see them being used. Hypertension, again, is an option, but it's really not a first-line med. Now, loop diuretics, as far as their adverse drug reactions, all of those things that I said were inhibited from being reabsorbed into the body are going to be things that are decreased. So hypokalemia, hypomagnesemia, hypocalcemia, hyperchloremia, and hyponatremia can all be low, obviously, because they're being stopped from being reabsorbed into the body. The only 2 things that are going up are going to be hyperglycemia, your blood sugar, and then hyperuricemia, so your uric acid. The way that I remember that is I remember hyperglycemia, that's a G, and then instead of remembering hyperuricemia, I just remember gout, and then I remember both of these start with a G, glycemia and gout, and then I just think of gaining or growing, so going up, And I just remember that, and I remember these are the only two that are going up. So that might help you, might not. It's not a great mnemonic, but that's how I remembered it. Now, this is the one you really need to know. They're not always going to ask you so much about the electrolyte abnormalities and things like that, but autotoxicity for loop diuretics is huge. That's always going to be asked, and that's something you really need to know. They love to ask that. So when you when you give these drugs intravenously and you fuse them too fast, these patients can have hearing loss. It's normally going to be temporary, but they can have autotoxicity. So that's a really important one for you to remember. Now, another one I'm going to put with a question mark, but this is something that you may be tested on, but studies are showing that this may not be 100% true, and it eventually may be out of the literature. But as of this point, you should know that there is a potential for patients who have a sulfa allergy to have a cross-reactivity with loop diuretics, that they may have an allergy to this as well as the thiazides. But again, this is being questioned, and it may come to a point where it's no longer believed to be true. But at this point, you should know that that is a possibility, sulfa allergy cross-reactivity. So a final note I want you to know, and I did not mention this medication in the loop diuretic meds because it's very rarely used. But with that being said, it is commonly asked for some reason, so I think you should know it. So if you're asked, what loop diuretic would you use in a patient with sulfa allergies or a history of gout, there's a very rarely used loop diuretic known as ethacrynic acid. But even if something's rarely used, it doesn't mean they're not going to ask you about it on the boards. And I only tell you about things that I remember being asked in school. So remember that ethacrynic acid. If for some reason they say you want to use a loop diuretic, but the patient has gout or they have a sulfa allergy, remember that's the one you're going to use because that doesn't have either one of those problems with it. So remember that. Now moving on to calcium channel blockers. These medications are nicardipine, amlodipine, verapamil, nifedipine, and diltiazem. So all different endings. So it's not like an easy one like Pril with the ACE inhibitors. But the way that I'll have you remember it is just remember the sentence, cut down Zempines and put them in the sawmill. So cut down Zem instead of them, cut down Zempines and put them in the sawmill. So remember all medications in the calcium channel blockers class end in Zem, Pine, and Mil, like Cardizem, Amlodipine or amlodipine, and Verapamil. So they all end in these three endings. So remember the sentence, cut down, instead of them, you say Zem, like with an accent. Cut down Zempines and put them in the sawmill. So cut down Zempines, like pine trees, and put them in the sawmill. So remember that sentence, and you can remember if you see Zem, Pine, or Mill, it's going to be a calcium channel blocker. Now the mechanism of action, it depends on which one we're talking about, whether it's the dihydropyridines or the non-dihydropyridines. Now the dihydropyridines are mainly just going to vasodilate. They bind to and block calcium channels, which decreases smooth muscle contraction and dilation of the vessel rather than vasoconstriction. So because of that calcium channel blocking, the muscle can no longer contract and it dilates rather than vasoconstrict. So it's all about vasodilation with the dihydropyridines. Dihydropyridines are going to be nifedipine and amlodipine. Now non-dihydropyridines, this is really important, verapamil, diltiazem. These medications, in addition to vasodilating, they do that as well, but they also slow conduction through the AV node, and this leads to decreased cardiac conduction and contractility. So remember that because these medications have a lot more utilities than just the dihydropyridines. They can be used in a lot of arrhythmias, and they have a lot more problems too because of that. But non-dihydropyridines, remember you're adding on both the decreased cardiac conduction and contractility. And the way that I remember that is the only two meds in this class are diltiazem and verapamil. Both non-dihydropyridines, they both affect the AV node, slowing the heart rate. So I remember they decrease the velocity of the heart because they slow the heart rate, decrease velocity, diltiazem, verapamil, decrease velocity. So remember that. You can remember which meds are in that subclass of the calcium channel blockers. Now, calcium channel blockers, the indications, there's a few outside of hypertension, but they are first-line monotherapy for non-complicated hypertensive patients, but then they have some other uses as well. So the non-dihydropyridines, again, like I said, because of the effect on the AV node, they can be used in arrhythmias. Migraine prophylaxis and verapamil. And Raynaud's phenomenon is another big one too. That's one of the first-line pharmacologic therapies for Raynaud's phenomenon. And then esophageal spasms, which is another one where calcium channel blockers, because of the relaxation on the smooth muscle, can help in things like jackhammer esophagus. So those are some other utilizations for calcium channel blockers outside of being first-line monotherapy for non-complicated hypertension. As far as the adverse drug reactions, the two big ones that I always found came up in real life in patients that I see that are on these, as well as on the boards, is going to be peripheral edema. These patients can have some swelling in the lower legs, as well as constipation. There are some culprits within the class. Some of the medications cause it more than others. But remember those two. Those are going to be the ones that you're going to see most often, peripheral edema and constipation. It also can cause headaches, which is a little weird because I just said that they can, they're migraine prophylaxis, but they can cause temporary headaches because of the vasodilation. They can also cause some dizziness, a little bit of hypotension. Those are the main ones you'll see, but remember peripheral edema and constipation. Now they do have some contraindications / cautions. Patients with congestive heart failure with left ventricular dysfunction, you don't want to use these medications because, like I said, they can weaken the contraction of the heart. So you don't want to use them in patients with left ventricular dysfunction to make the heart beat even weaker than it already is. Also, patients with any kind of these 6 sinus syndrome, 2nd and 3rd degree heart block, severe bradycardia, you can worsen these conditions. They're absolutely contraindicated in 2nd and 3rd degree heart block. If they have a 1st degree heart block, you technically can use them, but you really need to be cautious and probably better off to choose another agent because, again, remember the effect on the AV node. This can worsen all of these syndromes, so you want to make sure you avoid them in these types of syndromes. And then also patients taking beta blockers because you're going to double up on that, on decreasing the contractility and the conduction of the heart, and you'd want to avoid these in patients taking beta blockers. Now moving on to beta blockers, which will be our next class. We only got a couple left here and then we'll be done. So the beta blockers, medications in this class, not all of them, there's a couple exceptions, but most of the meds in this class are going to end in olol. So that's going to be bisoprolol, esmolol, atenolol, metoprolol, propranolol, nadolol, and then the last two oddballs, which are going to be the ones we'll go over in the end, are carvedilol and labetalol. So you can see that ends in a, instead of an olol, it's an alol, and then it's an ilol. So those are the ones that are just oddballs out of the rest, but the rest of them all end in olol. So there are a few different subclasses you need to be familiar with the beta blockers. There's 3 different subclasses that we're going to go over. So the first one, actually let's go over really quick because this is going to be important for what I'm going to go over next. Now you need to be familiar with where your beta receptors are because we're going to go over some different cardioselective, non-selective, and talk about which beta receptors they affect. Now beta 1, you can remember beta 1 because you have one heart. So beta 1 is found in the heart. It's also found in the kidneys as well, but for what we're learning about today, let's just focus on the most important areas that the beta blockers are going to affect. So beta 1, remember you have one heart, and then beta 2, you have 2 lungs. So beta 2, remember beta 2 is found in the lungs. It's also found in the uterus, some other areas as well. But again, remember, let's focus on what's important for today's lecture. So beta 1, you only have one heart. Beta 2, lungs, 2 lungs. Now, cardioselective are going to be the first beta blocker class we're going to go over. Cardioselective are only going to affect the beta 1 receptor in the heart. So they don't affect beta 2, they don't affect the lungs, which will be important with something I'll go over in a minute. Now, the medications in this class are the main ones that you'll see are going to be bisoprolol, esmolol, atenolol, and metoprolol. So the way that I remember that is that I remember bisoprolol, esmolol, atenolol, metoprolol, all those letters spelled beam. And I think cardioselective beta blockers only affect beta 1 receptors. They're very selective and direct, like a beam of light. You can see like a beam of light is just like this direct beam. It's very selective in where it's affecting. So remember, if you can remember beam of light, you can remember the 4 meds that you're going to see in the cardioselective beta blockers, the ones only affecting beta 1 receptors in the heart. Now, non-selective beta blockers, they're going to affect both the beta 1 and the beta 2. So remember, that was the heart and the lungs. Now, this can be a problem because if we're affecting the lungs, the beta 2 receptors, it can be a problem in patients with pulmonary disorders like COPD and asthma. Now, why is that? And it's because when you block the beta 2 receptors of the lungs, this can actually produce bronchoconstriction and exacerbate some of these pulmonary disorders. Like so, patients in COPD and asthma, this can actually make their symptoms much worse, bring on an exacerbation. So you generally want to avoid these non-selective beta blockers because they're going to affect the beta 2 receptors in the lungs. So the medications you'll see in this class, really the one that you need to focus on is propranolol. That's the one you'll see most commonly used, mainly because it has so many utilizations. The rest of these, nadolol, timolol. Timolol also comes in ophthalmic drops as well, but propranolol is the one you'll see most commonly used. And your non-selectives are your first generation beta blockers. So they're not used as commonly, but again, propranolol you'll still be seeing used pretty frequently because it does have a lot of utilizations. It can be used in prophylaxis for migraines. It can be used in patients with hyperthyroidism. There's a lot of different things that you can see it used. Essential tremors. We'll go over that later. Now your non-selective, the last ones we'll go over, and that's going to be your weird ones, your carvedilol and your labetalol. So they're going to affect everything. They're going to affect your beta 1, your beta 2, and even your alpha receptors. They really don't care. They could care less where they affect. So that's carvedilol and labetalol. They'll affect all the receptors. And again, these are the ones that don't end in olol. They're the oddballs. So they could care less which receptors they affect, and that's how I remember it. Carvedilol and labetalol could care less which receptors they affect. They affect all the receptors. So remember, carvedilol, labetalol, care less. They could care less which receptors they affect. They'll affect all of them. Now, moving on to the mechanism of action, the way these work is they block the action of catecholamines, of the endogenous catecholamines in the body. So epinephrine, norepinephrine, they block the beta and alpha receptors where they bind. So you need to remember what the purpose is of epinephrine and norepinephrine, your catecholamines, to make sense of why these medications do what they do. So catecholamines have a number of actions in the body. They can increase heart rate, they can increase your blood pressure, and they can also relax and vasodilate the bronchioles, which makes it easier to breathe during times of stress or exertion. So think about blocking all of these things. You're going to have the opposite of everything. If you're going to block these beta and these alpha receptors, instead of your heart rate going up, it's going to go down, which we know is one of the common uses of beta blockers. Instead of your blood pressure going up, it's going to go down. And then remember, if we block the beta 2 receptors, we're not going to vasodilate the bronchioles. We're going to vasoconstrict the bronchioles. So we're going to do the opposite. So that's why you're going to have some of these exacerbations in these patients with pulmonary disorders. So if you understand what action you're blocking, you can understand the effect that it's going to have in the body. So your indications, hypertension, it's not going to be first line. You're never just going to give somebody beta blocker right off the bat for non-complicated hypertension. It's only going to be in patients that have pre-existing systolic heart failure, coronary artery disease, but otherwise you're not just going to give it for a normal patient with hypertension, just not used that way. It can be used for migraine prophylaxis. This is normally the propranolol that's used, but it can be used for migraine prophylaxis, so that's one important thing that you need to know as well. It can be used for essential tremor. Again, this is going to be your non-selectives, your propranolol, and then acute coronary syndrome too. That beta blockers do have an effect because you want to slow the heart rate of the heart so it doesn't require as much oxygen. So acute coronary syndrome and then arrhythmias, it does have some potential for use as well. So those are some of the indications for beta blockers. Again, remember, it can be used for hypertension, but not as a first-line med, only when patients have these pre-existing syndromes. Now, as far as your adverse drug reactions, this is a big one that you need to know. So they can actually mask the symptoms of hypoglycemia. So you want to be careful when you use these medications in diabetic patients, because one of the main symptoms of hypoglycemia is going to be an increased heart rate, which beta blockers will prevent. And they also prevent or they block some of the noradrenergic or sympathetic system response that normally takes place in a diabetic patient. So normally when a diabetic patient goes low, they get shaky, they get anxious, their heart rate goes up. Beta blockers block all of these things. So diabetic patients can sometimes be unaware of their low blood sugars, which can of course be very dangerous. So remember that. You want to try to avoid, if you can, beta blockers in diabetic patients. Now, there's a few other things that I want to mention, but I don't want you to go crazy remembering these, because there's been some question whether or not these are true. So the fatigue, impotence, and depression. The depression, there's actually some new research stating that this may not be entirely true. You probably should know for your boards, because in the past it's been something that has been a side effect that they've kind of agreed upon. But as of the past couple of years, there's been some new research stating that this may not be true. And the fatigue and impotence, again, less so than they previously thought, but there may be a slight increase with beta blockers. So be familiar with those. But again, I also like to let you know the most up-to-date with all of these things, but definitely no masking the symptoms of hypoglycemia. That's a big one. Now, contraindications, some of these are going to be similar to the calcium channel blockers because of the same reasons as in the non-dihydropyridines, but absolutely do not want to use these in second and third degree heart block for the same reason. It can lead to serious bradyarrhythmias. Decompensated heart failure. So these drugs are great for patients with heart failure they're first line for patients with heart failure along with ACE inhibitors. But if these patients have decompensated heart failure, so an acute episode, worsening heart failure, dyspnea, etc., you're actually going to want to discontinue use of the beta blockers. And that's because they could potentially worsen the acute heart failure due to the negative inotropic effects that they have. So you can't risk decreasing the contractility of the heart during an acute episode, decompensated heart failure, so you want to discontinue them. And then, of course, your non-selective beta blockers like propranolol, you want to avoid those in patients with pulmonary conditions like CHF and asthma. So those are some of the things that you need to know as far as your contraindications. Okay, we are almost there. Let's go on to Alpha-1 blockers, and then we'll wrap it up. And this one's going to be pretty quick because there's Alpha-1 blockers are not a really high-yield hypertension medication. They're not even very commonly used. So let's just go over a few things that you need to know for that. So Alpha-1 blockers, all the meds are going to end in zosin. So prazosin, doxazosin, terazosin. Those are the ones that you should be familiar with. Indications, really, there's one thing and one thing that you need to know for these meds. They're not going to be used in first-line hypertensive patients. They're really only going to be used in hypertensive patients who also have BPH, benign prostatic hyperplasia. So really that's the main thing you need to know with your Alpha-1 blockers. Only time you're going to use these in hypertensive patients is if they also have BPH. So that's really I'd say the main thing, the only thing. There's a couple other things, but that's one of the main things you should know. Now the mechanism of action, they block the Alpha-1 receptors, which leads to vasodilation of vascular smooth muscles. So that's the way that they work. And as far as the adverse drug reactions, the main one you need to know is your first dose syncope and hypotension. It's actually one of the main reasons that we try to avoid these in elderly patients because of that. So this is going to be pretty severe. And it's one of the main adverse drug reactions with this medication that you need to be familiar with. It can also cause some dizziness, again, related to the hypotension. Headache is possible. And the nasal congestion due to the vasodilation of the nasal mucosa with these medications. Now, contraindications or cautions, you want to be careful, like I said, using these in elderly patients due to the increased risk of syncope. And then patients having eye surgery, there's actually something known as floppy eye syndrome, and you can take a look at that here. So due to its effect on the smooth muscle and vasodilation, it can cause a loss of smooth muscle tone of the iris. And during surgery, a patient that's actually having surgery on the iris can actually prolapse and potentially tear or rip. So it's contraindicated before surgery of the eye, and you can see what that looks like here, where the iris just completely prolapsed and tore here. So it's pretty dramatic and something that you want to avoid, obviously. That's your Alpha-1 blockers. That's the last med we'll go over. Let's just test your knowledge real quick with 5 quick questions. Which hypertensive medication class should be used cautiously in diabetic patients? Hopefully you remember beta blockers due to masking the symptoms of hypoglycemia. Which medication class would be best to use in a patient with both hypertension and BPH? We just went over this, so hopefully you remember your Alpha-1 blockers, terazosin, and some of those other zosin medications. Describe the main difference between dihydropyridine and non-dihydropyridine calcium channel blockers. Main thing, dihydropyridine only vasodilates, while your non-dihydropyridine vasodilate as well as influence the cardiac conduction and contractility. What are the 5 main adverse drug reactions of ACE inhibitors? Please remember this. I think that mnemonic was pretty good. So remember Chad, cough, hyperkalemia, hyperuricemia, angioedema, and dose 1 hypotension. And then last one, bisoprolol, esmolol, atenolol, metoprolol. What does that spell? Or what subclass of beta blockers? So beam, remember your beam of light. Cardioselective, they only block beta 1 receptors. Remember your beam of light. So that's it. I hope that was helpful. Thank you so much as always. I love the comments you guys are leaving me. I really do appreciate it. Please like the video, subscribe. Like I said, I'm coming out with a new video almost every single week now, and I'm going to try to ramp it up a little bit, try to get a little bit more out if I can. I know some people have been requesting pulm and things like that, so I'm trying to finish up with cardiology, and I'll get onto that next. So again, thank you so much. Please like, subscribe, and comment. I do appreciate that so much. And good luck on your PANCE, your PANRE, your EORs, and good luck in PA school.